DNA CPR stands for Do Not Attempt Cardiopulmonary Resuscitation. Essentially, it's a form of treatment that we'd be providing to patients who have a cardiorespiratory arrest. And it involves what we call a CPR, which is cardiopulmonary resuscitation, so chest compressions, using various drugs and a lot of invasive procedures. I think we have a duty of care to patients. I think it's important that when we talk about treatments, we're thinking about the risks versus benefits, the implications of not having this discussion, potentially putting an individual who is not a suitable candidate for cardiopulmonary resuscitation through the procedure itself, and essentially causing harm.
14 years ago, my mother had been suffering from dementia for some years. She also had heart failure, and she had kidney failure, and she had a heart attack. And they spent 4 hours struggling to bring her back. And at that point, my husband and I said, why? Because her quality of life was bound to be less when she'd come out of that. She was shocked. She was deprived of oxygen, and of course, she went downhill after that. And at that, we both said, we don't want that. So when it came to talking about the advanced care plan with my husband, it was very easy for me because I knew what he wanted when he was in his right mind.
If you have, say, a bad heart attack in hospital and what you have to go through, and it could be worse than passing away, you know. And you see, you don't know things like that, do you?
A lot of people believe that DNA CPR means that we're just giving up on a patient, but all it means is that we won't attempt any CPR. So it doesn't mean that we won't give oxygen, we won't give antibiotics, we won't do anything. It only means that we can't do, because once we've obviously agreed with a patient, if they don't want it, if we were to do it, then that would be a breach of that contract with the patient.
So some of these decisions regarding do not attempt cardiopulmonary resuscitation are quite obvious when they have to be made when the patient arrives in hospital, but often what we do find is there's a delay in these discussions, and I think it's quite important that these discussions happen as soon as the clinician recognises that potentially there's a risk of deterioration. I've been involved in cases where these discussions are often left towards the end, and too far on they become drowsy, they lose consciousness, and we've lost the opportunity to inform them of their treatment choice.
My husband has had gradually deteriorating dementia for almost 10 years, and he's in a nursing home now. We had a bit of a crisis about 3 months ago when he was found unconscious, and he was taken to hospital. He was in A&E. It was a very unpleasant experience, and when we came back, knowing his circumstances, knowing his situation, he's got Lewy body dementia, which brings Parkinson's with it. He's suffering from heart failure, and he's now doubly incontinent. And I thought, I don't want any more interventions. If anything should happen, can we make it possible for him just to be kept comfortable, but let go? So I approached our community matron very, very cautiously, because I didn't know who to ask. And it was Julie, who said, yes, you can do an advanced care plan.
If you're in hospital, the very fact that you're in hospital, you're unwell. And it's quite a stressful situation. It's upsetting for the person, it's upsetting for the family. You're wondering about the condition, what's happening, and treatments. And so if you can have those conversations out in the community before all that crisis happens, and in a more relaxed way, when the person is chronically stable but pretty well, then that is just so much more important and a better place to do it.
My mum was amazing. I think everybody says that about their mum. She was my best friend and my mum. She lived for her family. She looked after my dad, and she had me and my brother and then lots of grandchildren, and she was very hands-on. Because the first conversation was with our community matron, who'd been involved in looking after my mum and dad for quite a long time, and there was a relationship there that my mum and dad saw that person as a friend, so there was a lot of trust in that person. So I think it was good that it came from that person, because it didn't feel quite as harsh. It was more of a conversation and a chat, and felt more informal than sort of being put on the spot with quite a difficult question.
Sometimes I've gone into a family member on that first visit, never intending to explore that. I don't go in there thinking, right, I'm going to have this talk about DNA. It's about going in and assessing that family. And I've had somebody say within that first visit, oh, I've had enough. I'm fed up of going in that hospital. I've had enough. And so as a clinician, you cannot miss that golden opportunity. You've got to go on from that and say, why are you feeling like that, and then what are your thoughts and wishes about it? What are you prepared to put up with? And open up that conversation, because it's when you get an opportunity like that, we have to have the courage to open up those conversations.
I don't think initially I would have had a great understanding of what it was, but through the several conversations we had, you kind of understand that it's not that someone's being given up on, which is your first thought. It's more about planning and about making the right decisions and making sure that, in my case, my mum had the right choices, the right decisions, and everything right for her. About deciding that when she was too poorly, not to resuscitate, because it wouldn't have really benefited her and the quality of life that at that point she was having.
In an ideal circumstance, you want to take patients and relatives to a quiet room. You want to be switching off your mobile phones or handing your bleeps over to other colleagues, so there's minimum interruption. And then establishing what the cause for the admission is. I think it's important to establish what their past history is, what their quality of life has been, and what they've come in with. And then eventually get into discussions about sealing of care and do not attempt pulmonary resuscitation if we think that's suitable at that point. And I think it's explaining in layman's terms what this actually means. If I go ahead and say we're going to not attempt cardiopulmonary resuscitation, it may not mean anything to that specific individual or family if they've not been through this before. When we've had this discussion, it's always important to check this understanding. So ideally what I do is I'll give them a few minutes to gather their thoughts, and then I'll just ask them to summarise what they think I've mentioned to them. And I think if they've come out and then explained exactly what I've said, that checks their understanding. If patients do have capacity to make decisions, it's important to have these discussions with them and also ask them for their consent to speak to family members.
The advantage of having the family there is there's one conversation and everyone gets a chance to hear what the other person knows. When the conversations have happened separately, people might start saying, but don't tell me dad that because it'll upset him. Don't tell me dad that because he'll give up. And almost you create another problem. Where families are together, everyone heard that key message. We also like to transfer some of the information that was given onto the form. Now there's a limit to how much people can write down, but the words that are written on the form are crucial. So from a medical sense, we talk about medical futility, but that can be really hurtful for a family member to read that on a form.
It's important that every aspect of this form is filled in accurately. So patient details, next of kin details, and then it gives us 4 options on there. The first option being it's the patient's wish that they do not want to be resuscitated. The second option being they've got an advanced care directive, so they've got a plan in place. Now often when this sort of a circumstance arises, we need to be able to see that formal legal document, and do not attempt pulmonary resuscitation should be documented in there. In that case, we can use option B. Option C is when you weigh out risks versus benefits and you think there'll be no overall benefit. And this is typically used in scenarios where patients may lack capacity or have declined to have a discussion. And option D is the most commonly used. So for example, if someone came in with chronic kidney disease or congestive cardiac failure, and those were the reasons, you would be saying we cannot offer cardiopulmonary resuscitation, we'd use option D. And then it sort of then allows the clinician to sign that form with contact details, where they work, and their GMC registration number, so that it's a full valid form. So if someone had a question about it, they know who they can get in touch with. Every discussion that we have, and subsequently filling the forms out, we need to be discussing with patients and their relatives how long this form is valid for. So for example, if someone came in with an illness that you thought was irreversible, but there was an opportunity to treat this, you could put a review date. So you could say, we need to review this form on discharge. So if they get better from this and they're going home, then we need to review the form on discharge. So that could mean either cancelling the form or putting a further review date or making it valid till end of life. To say that, look, they've got a long-term condition, things are not going to get better, we're putting in a do not attempt resuscitation form, and we're also going to be ticking this box saying that it's going to be valid till the end of life. And I think one of the useful things in this is that this form can then be transferred into primary care, into the ambulance services. So once it's there, it's a valid form that other multidisciplinary teams can also use. So if, for example, they were to be admitted into another hospital, they know we've already had this discussion.
To ensure seamless care between community and hospital and with families, it's really important following these conversations that we ensure people are aware that conversation's being had, that family discuss it with other family members, to ensure that they're not shocked by it, or if they're there at the time, that inappropriate treatment is not initiated. And as clinicians, we need to talk to each other and make sure that if a patient goes into hospital, that we ring through, we explain we've had this conversation, that there is a DNA CPR in place, because that piece of paper doesn't always get taken in, because for whatever reason it was by the telly or it was on, it was somewhere, and in that crisis situation it didn't follow the patient.
A large number of my patients who have chronic long-term conditions, the majority of the patients that I've discussed this with do at the end come in and say, well, thank you for having this conversation. I'm sure it wasn't easy for you. And I look at that as we have provided compassionate care. We've taken their thoughts and their considerations into account. We're doing what they want us to do. And essentially we're providing that palliative care.
I wouldn't even have been aware of it. I think it was because of what happened to my mother that it brought into our awareness the horrors of that. And it was only because of that we decided we'd explore it, and we did it. And you need to do this when you're fit and well and you know what you're doing. And I think, again, that's something that we all need to perhaps raise awareness of, that these things need to be thought about before the moment.
Think what you can do now, what you're doing, and what you like doing, and think about if something happens, you had a bad heart attack or a stroke, and what you'd be like, and could you really put up with it,
It is a difficult conversation. It's not something that anybody wants to have. I'm sure as a clinician, they probably wouldn't want to have that conversation. It's probably not going to be the highlight of their day. It's probably going to cause emotions and upset and maybe anger. But it's a great gift to give somebody, really, because it's important, and it does open up conversations for families. As hard as it is to have the conversations, it made a big difference to us having the chance to plan things, and at the time it wasn't easy, but now in hindsight I'm glad that everybody kept having those conversations with us.